Okay, I'm going to have to make a leap of faith here. I'm going to have to assume that you can see what's on my screen. I'm going to have to start talking because I can't see your comments at the same time. If someone could just send me a WhatsApp to my number to let me know if you're actually seeing what I'm going to be speaking about, that would be great. But I'm just going to go ahead and start presenting and assume that you guys can see my screen because I have no communication with you. So thank you for coming to the presentation. This presentation is called Coping with Infant Feeding in Emergencies. And it's, thank you for coming on. I know there was quite a lot of interest in this from Indigo's partners and Help Refugees partners. So I'm delighted to be able to speak to you here today. My alternative title for this presentation is Don't Drop the Baby. That might sound rather odd, but I guess the reason that I call it that is because it's a very basic skill, being able to care for mothers and babies after they've had their baby. And sometimes people make it out to be very complicated. They say, you know, this is something we can't do. We're not trained. We're not specialists. And of course, in westernized, resource-rich countries, indeed, people do have quite specialist training to take care of mothers and babies after the birth. Thank you, Meg. I hear you can see me perfectly, so thank you. That reassures me that it's worth to keep going. So I want to be realistic for this audience. We're all in, presumably those of you who are online here are in emergency type situations, as we work in Greece when we're part of the cheering organization. And so this is a presentation that's really aimed at helping those of you who work with refugee populations recognize the importance of infant feeding and how much of an impact it can have on mothers and babies, both short and long term, and giving you some kind of a handle on the practicalities of how to deal with this situation that you're in. These are a couple of pictures. This shows Irini, who I believe is also on the presentation. She is one of our people who works for me at Cheering and indeed directs the program in Greece. And she's weighing a baby here in Skaramangas. And this is our measuring equipment. So you know, as I say, it's pretty basic, and weighing and measuring babies is probably the most basic and the most critical thing that we do on a regular basis, because whoever the mothers are, from whatever corner of the world they are, in whatever situation, when they have babies, they want to know about three things. Is the baby gaining weight? Is the baby growing? And is the baby developing? And those things we can answer with some fairly simple tools. So I'm going to talk today about infant feeding in emergencies like the one that we're all living through right now, which is coronavirus, which is an international emergency. And also I'm going to give you a little, just going to go through a few slides at the end of a presentation that we have put together for the mothers so that you, and for families, so that you know what kind of resources we offer. I'll just give you sort of a taster of it. The poster on this slide shows the Arabic instruction for breastfeeding in COVID. It's put out by the WHO, and this one's available in Arabic. And basically it says, keep breastfeeding. There's a lot of words on there, but really it just says, keep breastfeeding and wear a mask and wash your hands. And this is for your future reference. We just wanted to give you some information as to how to contact us if you want to in the future. So I just want to give you a little bit of background about myself. I work at Boston Medical Center / Boston University. In fact, we're now the COVID hospital in New England. We have Massachusetts, where we're based, is one of the hotspots for COVID. We have 40,000 cases here at the moment. Boston Medical Center's intensive care unit has been full for over 2 weeks, and we're diverting to other hospitals. And the reason our hospital is so overwhelmed is that because we serve the poor community in the city, and due to all sorts of reasons that I'm sure you can all imagine, families who live in our catchment area that we serve don't have the luxury of socially isolating in nice apartments or houses away from everybody. They live in fairly crowded conditions. They work in the kinds of jobs that we all use these days, like supermarkets and Uber and delivery services, etc. So we have a very high incidence of COVID in our population, and in general, they tend to be fairly unwell. So unfortunately, as a group, they have obesity, diabetes, etc. So unfortunately, we're having a lot of deaths. So it's a very difficult time for our hospital right now. And I'm not a clinician. I'm not on the front lines every day doing. I'm not a doctor, but our hospital. I've been working here for over 25 years, so it's quite moving to be with the hospital in this time. Cheering is the Centre for Health Equity, Education and Research, and we are based at Boston University, which is attached to Boston Medical Center, but we work across the United States as our center. We have a particular focus right now on Mississippi, and we've done a great deal of work with the American Indian tribes. And Cheering is like our sister NGO in Greece. Cheering is completely independent from Cheer, but I run both of them, with Irene in Greece running Cheering. And Irene and I started Cheering together about 2 years ago. And our main focus is infant feeding and maternal child health in the perinatal period, which is the area I've specialized in my work for the past 25 years. This is our big team. We have people all over the world. I'm just looking here. I can see people from Nigeria, Malaysia, Afghanistan, the Congo, and many of these people are living in different countries still. We've got people living in United States, Canada, Greece, and other countries. So we have a great team, and they're wonderful. And just as information, although Cheering is separate from Cheer, we do have backup from people like doctors and nurses that work on our team so that we can always ask specialist questions if we need to. So our mission is to increase exclusive breastfeeding rates among refugee populations and to provide hands-on service and training to organizations on the front lines, which is you guys. We ourselves, this is one of our meetings a few months ago, but we ourselves, we provide direct service to families in Athens area camps and the Elna Maternity Centre, which is a shelter in the middle of Athens, very close to our office, which is pictured here, about 5 minutes walk. And we train nonprofits and agencies, and we collaborate with Greek organization called Galaxias, which is the main lactation doctors organization in Greece. And I don't believe any of the other NGOs offer this level of outreach, especially the training that we do. So we work in the camps. Of course, we have restrictions right now. We're not in the camps right now. We're doing a lot of virtual work with short videos and presentations and these kinds of trainings to sort of get ready so that when we go back in the camps, we haven't really missed too much of a beat. But we're currently working. These pictures show you at the top, there's Eleonas there, an off-site clinic next to Inofita, although we've started going into Inofita camp now, and Scaramangas there at the bottom. And the basic thing that we sort of did is to really start putting in some measuring equipment. We work with Solidarity Now in a lot of their camps, and one of our first steps with Solidarity Now has been to get weighing scales and measuring into all of the women's spaces that they're operating. When we go, for example, to Eleonas, we run a weekly support sessions. So we go in there with our weighing scale and our measuring tapes, and we see often the same moms and babies come. It's like, we call it a grow clinic. Basically, they're coming in, weighing and measuring the baby, and making sure that the baby's eating properly. And then we do have to screen a lot of more complex things. I mean, we're all trained in the basics of spotting problems. So, you know, if a child comes in and it's cut its foot and it's infected, we can look at that cut and say that's infected, go see a doctor. So we because mothers ask us everything because they don't really have access to healthcare, and of course we don't treat anything except for the nutrition part, but we do know how to spot things that are really problematic, and we alert the camps and the referral services as if we find things. We've detected children who have been semi-paralyzed. We've detected children with severe malnutrition, etc., etc. So we do kind of have to screen through clients. That's just part of what goes along with being in this kind of position. Yeah, so during these sessions, we weigh and measure the babies and we track all the babies on growth charts. I think that's really important because that shows us how they're growing over time. It's no good to just go in and weigh a baby once. It doesn't really give you very much information. You need to see whether that child is growing on a steady curve over the course of several weeks or months. And then we also talk to the moms. They always have questions about nutrition. I don't think I'm making enough milk. What is my baby sick? And so we do a lot of monitoring and supporting of breastfeeding, and we try to see them when they're pregnant, because then we can give them some reassurance up front about how to handle breastfeeding when the baby's born. So sort of stepping into the theme of this about emergencies and feeding. I mean, what is an emergency? Well, for once we have kind of the attention of the entire world here, because usually when we talk about emergencies, we're talking about a specific event like a hurricane or an earthquake in a certain location. And other people that aren't in that location feel protected against it. But right now we've got an international emergency going on, which is coronavirus. And so, what else is an emergency? Well, we know that these sort of one-off events obviously are emergencies. War is also an emergency. And I would vote for the fact that refugee and migrant living is also an emergency. And indeed, extreme poverty and poor living conditions around the world are also emergencies. So many people live in an ongoing state of emergency. And some of the things that only apply to some of the resource-rich countries right now in this emergency apply everywhere else all the time. So it's a kind of interesting shift, especially when I'm presenting in the United States. People haven't really been used to these kinds of conditions before, or considering these conditions. What would the priorities be in an emergency? Well, health, food, and apparently toilet paper. But it kind of really goes to the basics. Health and food are the kind of big ones. So all emergencies, whether you're talking about the ongoing emergency of extreme poverty and famine, or the emergency that's happening right now, something temporal, they have a lot of things in common. People have poor access to basic necessities. They can have unreliable power or fuel, not clean water often. Then that said, there's nowhere to boil or sterilize the water because they don't have access to power, or they don't have access to the tools. And then in our topic of infant feeding, often the infant feeding, the formula that they need to buy is insufficient or costly or simply not there. So people can't access formulas. Of course, they use something else instead. And in general, in any kind of emergency, including those that are ongoing, you have high stress levels and poor health. And so the routine recommendations for COVID, sort of just exemplify how routine recommendations are really quite useless. Wash your hands with hot soapy water. Well, probably most of you on the call could do that on a fairly regular basis, but I wouldn't say that all people living in emergencies can do that. Use hand sanitizer. Even in Boston, you can't buy hand sanitizer, so that's not very helpful. Boil the water, depends where you live. Wear a face mask. Well, as we know, everyone's making cloth face masks these days because there aren't any good ones. Even for the healthcare providers, there's not enough equipment. And actually, we have absolutely no idea if these cloth face masks work. They were banned at my hospital because they said they don't work and they carry the risk of infection if you take them home and take them off, because people are not trained to sort of treat them as hazardous material. So if there's face masks lying about in the caravan or the tent, then that's just a hazardous source of infection in and of itself. So that's not a very realistic recommendation either. And as you all know, telling the refugees to sleep in separate rooms and when they're living in crowded conditions, or even go see a doctor, is not very realistic. So a lot of these things just don't apply. And there was a nice article in the BBC about, how the hand washing recommendation just didn't work for millions of people because they just don't have access to lots of water and soap all the time. Yet these organizations continue to recommend these things. So I would say that the exact same thing applies to routine formula feeding instructions, which say always boil the water, sterilize the bottles, use the right amount of formula, read the instructions, etc. You can see it. So, well, reading the instructions, if they're not in your language, can be impossible. Well, it can be impossible. It is impossible. And of course, often people are not, some people sometimes are actually illiterate, so they can't actually read the instructions at all. And if the formula comes from China, we can't read Chinese when we're in a Greek refugee camp, unless, you know, there's happened to be someone Chinese there. Most of the refugees certainly can't read even Greek. So it's extremely difficult to know how much formula, and people just guess. I mean, they do guess. When I ask them, they say, I guess. And that's no good, because formula has to be perfectly diluted at the right concentration. Otherwise, you can dehydrate the baby or underfeed the baby. And of course, since it is so expensive, people will dilute it. They'll add too much water to it, which again means the baby's undernourished. They may or may not refrigerate it, but I know you've seen people walking around the camps and the streets, and this is not just refugees, anyone, but in general, people carry the bottles of formula around with them all day long, and so that's not healthy either. Any formula that the baby doesn't drink in that feed is supposed to be discarded, which you can imagine, if someone's used so much of their money and resources to purchase formula, they really don't want to throw it away. So either they don't throw it away, or they overfeed the baby in that feed to get the baby to eat it. And then they're supposed to do all this 8 to 10 times a day. So it's completely unrealistic to formula feed in these kinds of situations. This horrible picture, this is from the WHO, and this shows a woman who fed twins, and she was told that she would not have enough milk for 2 babies, which is not true, because the body is supply and demand. So if you have twins, you'll make twice as much milk, because the breasts get twice as much milk removed, and therefore replace it at twice the rate. But she was told that she should not breastfeed both of the twins, so she chose to breastfeed the boy and bottle feed the girl, and the girl died very shortly after this picture was taken, and the mother said, please use this photograph if it will help other people. So we maybe tend to forget sometimes in our resource-rich environments that not only do people not have those basics we mentioned, but they may not have access to vaccinations, and we see this all the time in the camps, that young babies are not being vaccinated. You know, that's another thing that maybe this epidemic will raise, the spectre of epidemics, and much worse epidemics. If you have something like measles and you don't have vaccinated children, there are diseases that affect children a lot more than this disease is doing. So vaccinations are not there all the time. They don't have access to antibiotics or other things. So, you know, if we're formula feeding in the Western nation, it's very unlikely the baby's going to die. The baby's going to have some long-term potentially health problems, but it's not going to die because we can correct for infections and things with antibiotics, but that's not always possible in the camps. They don't have access to routine or consistent medical care or consistent advice and support. So there's all sorts of myths going around about breastfeeding, whether you should or shouldn't do it. And then they may not have any family support. And we found like women who've left their mothers behind or their mother-in-laws behind, and really in some cultures, it's the older women who help the younger women with the childcare and the breastfeeding advice. So they haven't got that advice, or they might be getting long distance advice that is not the best. So, it's not, there are many other factors that are involved in refugee situations that can cause them not to have support with breastfeeding, and for the breastfeeding to be all the more important. So really, it's not an ideal situation. It's a realistic situation that women need to breastfeed. People can't afford formula, it's not safe, and people use alternatives. But I would say that you can make the difference, those of you who are working with refugees, and you can probably make more of a difference than you even imagine. Just to sort of illustrate something that we've seen in the camps, because of the cost of formula, when people feed alternatives, we often see people feeding cow's milk to young babies, just straight cow's milk, and adding sugar or water, and that's really inappropriate. They say that the sugar is to give the baby energy, but children under a year shouldn't have cow's milk, and certainly children under 6 months should not have any straight cow's milk. Cow's milk is completely different from human milk, so cow's milk is not a reliable substitute, or it's not going to have them grow well. They'll get diarrhea and malnutrition. The actual exclusive breastfeeding recommendation from the World Health Organization is for 6 months. So women should only give breast milk for 6 months, and then continue to 2 years or beyond, starting solids at 6 months. So depending on the country you come from, some of you may think, goodness me, 2 years, that's a very long time, whereas other countries feed till they're 3 or 4 years old. The WHO likes this 2-year recommendation for a few reasons. One is that it prevents the child or protects the child against other sources of maybe not clean water, because they're using the breast as their drink, and that's always clean and it's always at the right temperature and it doesn't go off ever. And also it helps with child spacing, because the longer a mother breastfeeds, the longer fertility is delayed, and so it's not a safe method of birth control if they're not breastfeeding very often, but it does tend to delay the next pregnancy, so that gives women's bodies a chance to recover and it helps with child spacing. So that's another reason that the WHO likes a 2-year recommendation. But they do need to start eating solid foods at 6 months. One of the biggest reasons for that is the iron. The iron content, when babies are born, they get a lot of iron right at the end of the birth process, and especially if they delay cutting the baby's cord, they can get a lot of iron. But there's not very much iron in breast milk, and the stores of the iron last till 6 months or so. So they particularly need to start eating solids to get a rich source of iron, and of course other minerals and vitamins. Although really they don't rely on the calories from other foods until they're about 8 or 9 months old. So the WHO estimates that if we increase breastfeeding to universal levels, as their recommendations are, we would save over 800,000 lives every year, most of them in children under 6 months. And we prevent half of diarrheal disease in children and a third of respiratory infections in children. And because breastfeeding is protective against breast cancer, we would also save 20,000 deaths a year from breast cancer in women. And yes, that is for the women who breastfeed. The women who breastfeed actually have health benefits too from the act of breastfeeding. It protects against cancers of the reproductive system, and it also prevents against diabetes. In the short term, breastfeeding prevents acute outcomes. So when the babies aren't being breastfed in the camps, etc., there are outcomes that are acute. They get sick. We've seen it over and over. They have diarrhea. They have all sorts of complications, and so they have to go off to the hospital. That means that they have to be admitted. And of course, in an emergency like this, you don't want women being exposed to COVID or the babies. The other thing that you guys will see is, I'm sure you've interacted with women who haven't got any money and they're asking for money for formula. Or they're feeding cow's milk or just water, which has a short-term outcome of lack of nourishment, and also development is delayed. I've seen 7-month-old babies the size of 4-month-old babies because mothers are feeding them a lot of water because they can't afford formula. And all of that leads to more sick babies. So it's a sort of vicious cycle. When we talk about breastfeeding benefits in resource-rich countries, we really talk about all these other things as well, which is just not life and death. It's just benefits that persist for long periods of time. So in infants, breastfeeding lowers the risk of ear infections, GI issues, etc., etc. You can see that on here, but there are many benefits to breastfeeding, including at the bottom there, necrotizing enterocolitis, which is a disease of preterm babies, which basically kills the gut. So there are many, many health benefits that these children will be getting besides the short-term prevention of acute outcomes. And for mothers, we mentioned this. So there's a reduced risk of breast and ovarian cancer in mothers, reduced risk of high blood pressure, and a tremendous reduced risk of developing diabetes. So there are also benefits for the mothers who breastfeed. And I'm sure that those of you working with these moms and babies will also recognize that there's a huge benefit for things like that we can't necessarily measure, but self-esteem, for example, the pride that a woman takes in feeding her own child and being completely responsible for that child's growth and development is tremendous. She's able to control that. She doesn't need to ask for anything. She can simply breastfeed the child, and she can do it herself. It's very empowering and fulfilling. It provides a certain normalcy and a connection to her own culture, if that's what her predecessors have done with their babies. There is a connection there, and all women feel some kind of connection with each other when they're breastfeeding. It's a shared experience. And of course, it's free. And you know that the other big thing that no one can afford is diapers. So if they don't have to pay for formula, they have more of their cash to spend on other things that they need for the baby. So you may well ask, well, are there guidelines for this? Like, if it's so great, why aren't we doing it? Well, actually, we're not doing it because we're not following the guidelines, and that may be the fault of the guidelines. But there is this book, which is read on every few years, and it's actually exactly there in order to train people like you to operate in these conditions. And in my field of breastfeeding, infant and young child feeding is a whole sort of subcategory of field, and people are very familiar with it. But so this book was created by UNICEF as part of the WHO's global strategy on infant and young child feeding. And it has a whole program guide in here, how to apply these strategies and what you're supposed to do, and including the infrastructure down from the government and who's responsible for what, to minimize infant and young child mobility and mortality in an emergency. Unfortunately, these guidelines are not being followed in Greece. And before we sort of came in with that criticism, we did do a survey, and we talked to that time there were 6 camps operating in the Greater Athens in the Attica area. And we surveyed them all. We read what they had in their site profiles, which was published information, and then we interviewed the field coordinators in each camp. And nobody had heard of these guidelines. And in fact, don't quote me on this, but we rang up UNHCR in Athens. It was one of the authors of the guidelines, not them in Athens, but UNHCR, and they didn't know what they were either. The people that spoke with us didn't know. So although these guidelines exist, and although Greece is in the European Union, and it's not even that far from Geneva, actually, they're not known, and they're not carried out in the camps. And I'm sure those of you who work with mothers will see the same thing. So in terms of the actual protective quality of breast milk, breastfeeding actually protects baby from viruses. So it's particularly important during this emergency to breastfeed, because when there's any kind of virus in the air, the mother makes antibodies in her milk, and those antibodies are passed through the milk to the baby. So actually, we have not detected antibodies to COVID yet, but that's because we haven't actually figured out how to find out if there are antibodies and if that's a reliable test. I am pretty sure, based on things like SARS and other epidemics and other sicknesses, that there will be antibodies in the milk, because there always are, but we haven't figured out how to test for them yet properly in this disease. And also, human milk, it isn't just a food. It contains all sorts of fatty acids and other components that people have spent years researching. And we know that it's also the basis of the entire immune system in the baby, which is probably why it helps to protect against things like diabetes and other autoimmune diseases. So as the mother breastfeeds her child, that establishes the flora in the infant gut, and that's the basis for the whole entire immune system for the rest of the child's life. So I'm going to talk to you now a little bit. This slide is one of the slides from the WHO. I showed you one at the beginning about infant feeding and COVID, and this is the WHO has some great recommendations on this. Some of the countries, like the good old United States, have been really conservative and said, oh, well, we don't know if we should breastfeed or not, which is really, in my view, complete rubbish, because we should always breastfeed in any kind of an illness, because it's always protective for the baby. There's one or two rare exceptions. Ebola is one, but we're not talking about Ebola here. I mean, COVID is not Ebola. So we're talking about a respiratory virus, and we know from other situations that those kinds of viruses are protected to the mother's milk. So this is good for the WHO, because they've come up with some great recommendations. So the next few slides I'm going to talk you through, this is actually a presentation that we have created for our mothers. So you can download this is where it starts. Okay, so you can download these slides from our website, and I can tell you how to do that. And we have them in Arabic, Farsi, French, and we're working on Greek, and we're working on other languages, and we have many of these little presentations in Arabic already. So we're working our way through them. So let's just talk about what is coronavirus. So we imagine that this is something that is going direct to the mom. So we've tried to make these in fairly straightforward terms. That is not supposed to be patronizing, but we're speaking to a really wide audience, so we don't know the level of knowledge in that audience. And so we've pitched it at a comprehensible level, also because I just don't, based on my years as a journalist, people don't like reading things. So the shorter and sweeter, the better. So this is what we have for moms. So what is coronavirus? A germ that causes a disease called COVID-19, which has spread all over the world, and it infects the lungs and can cause breathing problems. How do you catch COVID-19? Germs like coronavirus attack our bodies from inside. If another person coughs or sneezes, you can breathe in their bad germs and get sick. And even if someone doesn't look ill, they can make you sick. Feeding your baby and COVID-19, what to do? So the WHO says women should breastfeed even if they get COVID-19. Breastfeeding protects from viruses, and breastfeeding my mothers with COVID-19 is safer than not breastfeeding. And then we show a WHO slide, which we also show this in Arabic if we're doing the presentation in Arabic. Other questions moms want to know: will my baby catch coronavirus? And this is probably helpful information for you guys too. So some babies do catch COVID-19, but we're not sure how. And most babies and young children who catch COVID-19 get better quickly and do not get very sick. It's one of the great advantages of this disease is that it does not affect young babies and children seriously. So there are, of course, you'll read a few horror stories in the news occasionally, but kind of like the other viruses that were sort of known as childhood illnesses, like chickenpox, for example, those illnesses really don't affect children very badly compared to adults. So we're very lucky that this one doesn't. So you can always reassure the mothers that actually this does not affect children and in fact young people very well, which may be why it's not devastating the camps, because the majority of people in the camps are young. So there's some saving graces. If you have COVID-19, keep breastfeeding because it protects the baby, but don't cough on the baby. Cover your face when you breastfeed and when you're near the baby. When sickness is in the air, the mother's body makes special cells that fights the sickness. These special cells go into the mother's milk. And when the baby drinks the mother's milk, it protects the baby against the sickness. Breast milk is always clean, ready, and healthy. And then, often people sort of say, well, maybe we should just avoid breastfeeding and bottle feed. So just a reminder that if you do not breastfeed, you have to be very careful in an epidemic. You must use the right amount of formula. Don't give animal milk to babies under 6 months, etc. You can see on this slide what we tell them. And then we have a piece of data in here. And then the common question, so mothers, okay, so you're telling me to breastfeed, but I don't think I can do that. So how am I going to know if I make enough milk? So we put something in on that as well. So if your breasts have developed normally, you will make enough milk. And just to all of those of you listening, you may have had mothers or grandmothers that said, well, I never made enough milk. That is very unusual. It's not unusual that they didn't make it in their day, because we were doing things in their day to people that prevented them making enough milk. So up until the 70s, we were recommending that babies feed on a routine. We were giving extra bottles. People weren't encouraged to breastfeed. There was very little contact often between the mother and the baby in the hospital setting, so the breastfeeding did not get off to a good start. But if you think about it all, guys, we are all mammals, and we would never have survived as a species if we didn't make enough breast milk. And no mammal species would have survived this long. I'm sure that, you think of rabbits, you don't think rabbits don't have enough milk, or dogs don't have enough milk, or giraffes don't have enough milk. We all have enough milk. It's just that we need to manage the breastfeeding in a way that will allow us to keep making milk. There are a few people that have hormonal problems that can't make enough milk, people whose breasts did not develop well during adolescence, etc. But they're very, very rare. So our encouragement here is to breastfeed from day one, and you will make enough milk. You don't need a special diet to breastfeed. Your milk will be perfect, even if you're living in a tent, container, or shelter. And your baby should poop and pee often and gain weight. And we do have to add the disclaimer if I don't see a doctor, although I know that many people don't have access to a doctor. It's important for us to recognize, for when we're talking to refugee women, that their milk will be perfect, because we do hear a lot of them being sent home from a hospital having been told that because they're living in unclean circumstances or they don't have good diets, they won't make good enough milk. And that's complete rubbish. They always make enough milk, good enough milk. There's nothing wrong with the milk. People have to be in a state of starvation, a real starvation, to have a problem with the milk. It's like pregnancy. The body will take what it needs to make the milk. Now, of course, women should eat well and drink well and not be undernourished, because their bodies will suffer just as they do in pregnancy if they're not well nourished. But it's not true that because they're living in suboptimal circumstances, there'll be something wrong with the milk. That's just not correct. Many people are surprised to know that a baby's tummy is only the size of a cherry on day one. And we have this in this presentation because this gives people a lot of relief to know that actually they only have to make about a teaspoon of milk in day one. And people are sort of thinking this baby should be drinking gallons of bottles of formula or something. And in day one, they make very little milk. They have very little milk, and they need very little milk. In the first days, a lot of it's just the immunological properties that are coming into the baby. So the colostrum is very, very rich in white blood cells. So you really don't need very much milk at the beginning. So if we've come this far, then people may have questions. Well, can I just stop bottle feeding and then breastfeed instead? And often professionals in your field ask me that question. Well, can we just help people to relactate? You have to be very careful about relactation. So this is, as you can see, this is tuned for women themselves. So if you're only giving a bottle a day, you can cut that, but you have to breastfeed more to make up for it. And again, it's supply and demand. But this is one of the inspirations behind the work that we do, and the weighing and measuring that we do, is that you can't really tell when you interview a mother necessarily how much breast milk she's giving the baby and how much formula. We've had it go both ways. People say they're breastfeeding and they end up actually giving lots of formula, and people say they're only formula feeding and you turn around and literally they're breastfeeding. So it's difficult to assess it objectively, and that's why we weigh and measure them. You can't just tell a woman who's been formula feeding to stop formula feeding and go back and breastfeed, because it depends how old the baby is, whether she's breastfed at all. If she's formula feeding a 3-month-old baby that's never been breastfed, then there's a very strong chance that she will not be able to make enough milk to breastfeed that child, and she certainly can't stop giving formula today and start breastfeeding tomorrow. The supply and demand element is important, and if they haven't been removing milk from the body, they want to be making milk to replace it. So it's not so simple. It depends. If they're just having a little bit of formula, then I strongly advise to get rid of the formula, because you're not only introducing formula, but you've got all the other risks that you go along with the bottle that you can eliminate. But you really need to know what you're doing to counsel women to stop bottle feeding and go back to breastfeeding. So I guess I'll leave this part of the presentation with this slide, which is one of my favorites. It's from UNICEF and their partners, that basically for a smart, sharp, strong baby, give breast milk only for the first 6 months. And that's kind of the overall message that we want to get out. So now, so I did mention our resources. I was just going to put that on. We have a 2-minute teaching tools, which is like the one I just did for you. We've gotten better and better as we've been doing these. We're shortening them and making them more and more punchy. And so we have got a bunch of little trainings there. And then we now have a YouTube channel. I'm very proud of our YouTube channel because we only launched it about a week ago. We have some live tape broadcasts that are 2 to 3 minutes long. And we have some in Arabic and English, and we're adding them every day. So we have got a lot of resource out there. And this was partly sparked by this epidemic, because we are trying to make these resources that are very short, that we're sending direct to refugee Facebook sites and things that we've asked permission to join. And we have a wonderful Arabic speaking person who works with us, Mariam, and she has joined a lot of these platforms. So we're able actually to send these teaching tools direct to the refugees as well, which is great. Okay, so now I'm going to go through this very complicated process of trying to not share my screen anymore. Okay, so I've got some questions. Please, would you type? No, you've got this lovely. Let me stop screen sharing, not end call. Oh, you should actually be able to see me. I don't know if you can. Anyway, if people have questions, please type them into the chat. Okay, I can see one question here, which is how do we deal with not being able to weigh and measure right now? So, a couple of things. One is this is one thing we have learned is our strategy of having people in the camps prepared and trained who live there is really important. And we don't have very many, but we have, for example, the shelter that we work with in Athens. We have a trained refugee there who is from Congo. She's wonderful. She did 1 year of nursing school before they fled Congo. So she has the basics of some of this stuff. And she does all the weighing and measuring for us. We've installed the weigh scale and the measuring tape, and she does it for us. And if she has severe, questions that are complicated, we can talk to her on the phone or over telemedicine, basically telemedicine support. There are weighing scales in most of the camps that we have. That's why so that's why we, for example, are training Solidarity now, because they can weigh the babies. They can just, all you need to do is just don't drop it, put it on the weigh scale and weigh it. I would strongly, strongly recommend, if you want to make a donation to a woman and baby space in a camp, send them a basic digital weighing scale. If they can't have a baby scale, you can use a person scale. You can get on it, pretend not to look at your own weight, pick up the baby and see how much the difference is. So you weigh yourself and then you weigh yourself holding the baby. So there are ways to measure the babies. And we are always willing to do kind of consults if people have a baby that they think is underweight. I'm not saying that it's easy right now, but I am saying that the goal is to get these into all the camps so that people can actually just weigh and measure their own babies. I mean, most babies do okay most of the time. They're incredibly resilient. There are going to be some that don't. But it would be very reassuring for women if they can simply weigh their own babies, and it's not that difficult. We should be empowering people to do these kinds of things. I mean, I work with an intensive care unit that has mothers going and weighing their own babies and even spinning their own milk for the high fat content. So there is a lot we can do actually, just by providing basics and training. There's a question that I'm not fully understanding, but it says, what would you recommend for treatment under camp conditions if the mother's breast got hurt? It depends what you mean by hurt. So we have two breasts. If we're talking about, breastfeeding and keeping that going, the cultures that breastfeed from only one breast. So it is not going to stop them from breastfeeding if one of the breasts isn't working properly. But breast got hurt. If Anna, if you could explain a little bit more what you mean by that. But like if you've got an infection in the breast, somebody needs to get antibiotics. So sometimes women can get pain in the breast, and it could be partly it's because of the latch. Oh, by the baby. Okay. Well, I'll just one of our other presentations, and if people are interested, we can talk about, we can go and do another of these trainings actually about the support that you can give, because we don't have time to address all that in this training. But I'm reading these questions coming in. One of the things you want to watch out for is a breast infection. Sometimes people's breasts get hurt, because if they're not latched on properly, if the baby's not properly attached, then the mother's breast is going to hurt. So I say if you imagine that this is the breast and this is the baby's mouth, okay? The baby needs to go onto the breast like with a big open mouth and compress the breast. This should not be on the end of the nipple. And actually our slides show that when you look at the short slideshow on how to feed the baby. So you want to make sure that if the baby's sucking here and it's really hurting the mother, she needs to take the baby off and reattach the baby. I have to say this is a really, really common thing in Western cultures that I work with. I haven't seen it as much in the camps. I don't know if people have better babies, but I haven't seen it as much in the camps. It can happen in the first week, yes, and it's mainly because the baby's not latched on well enough, and someone needs to work with them to make sure that the baby is fully attached to the breast. And when it gets teeth, most babies don't bite, but sometimes they do. If they have teeth and they're nursing properly, it won't hurt the mother's breast. They do sometimes bite because they think it's great fun, because they bite and the mother goes, ah, and this is great fun for the baby, and they sort of do it again, see what happens. So it's not much fun for mom. They need to not react, and there's ways to stop babies biting. It's quite easy, actually. You just say no, and you put the baby down, and you refuse to breastfeed them, and they get it really quickly. So babies can bite, but it's very rare. I mean, it's not rare, but it's not very much of it's a quite easy problem to solve. And it doesn't mean that just because a baby has teeth, they're going to bite the mother. And if the baby's sucking normally, the teeth are not an issue. Other questions, anybody? I'm curious how many of you do work with moms' babies, and whether you have, whether these kinds of things come up. I mean, we've seen an awful lot of moms coming home from the hospital with prescriptions for formula. It's really disheartening. I mean, I see that all over the world. I see that in the United States all the time, so I'm not surprised by it. But it's really a shame that people feel that, moms can't feed their babies. It's a huge thing for moms to be able to do in these circumstances. One thing we didn't discuss, which I can mention since I don't see any more questions, but please type them in. Yes, Sally, I saw that comment. Thanks. I will address that. There are a lot of women who are anxious and might be on medications, and that's a whole other topic. I will tell you that most medications are okay most of the time, but obviously you can't just guess that a medication's okay. So there are online resources actually that you can look up a medication, and it will tell you if it's okay or not. And don't act on this advice, but as a rule of thumb, antibiotics, for example, are okay, but psych medications, there are certainly some psych medications that are fine, but many psych medications are not. So what you can do is the mom can switch to one that's okay, that's compatible with breastfeeding, but that definitely needs to be kind of under the control of someone who is prescribing the drugs and can measure the mother's reaction. Okay. I have got two other questions here. So Sally asked me if I can mention the problems of milk promotion in the hospital. Yeah, and I have a whole talk on that too. But one of maybe the biggest problem that we face as a group is that it's not easy to get the message across, because the infant formula industry is enormous. Nestle is the biggest food company in the world, and it's not easy to promote breastfeeding when you have all these competing influences. So many of the hospitals have free formula. They take it for free from the manufacturers and they give it out for free to mothers. And that's against an international WHO code, but it happens anyway. And I don't want to say this about Greece specifically, but across the world, there are many healthcare professionals who are getting lots of kinds of incentives from formula industries to be able to distribute formula. So it's a big problem in the field, and certainly it's happened in all sorts of circumstances, including, for example, the third world countries in the 50s and 60s. Nestle was going in there and giving out a lot of free formula because it's supply and demand. It really undermined the mother's breast milk supply. So it's a really big area, and that's one reason that NGOs are not to give out free formula. And actually, we do find that is one of the things that is adhered to. My experience, we have not seen a lot of free distribution of formula in the camps, which is good, except it needs to be put in the context of everything else. Like if you don't give them formula, which you shouldn't do because you want them to breastfeed, you also have to support people to breastfeed, because otherwise you end up with the worst of both worlds. There's no support for breastfeeding and there's no formula either, and people are giving cow's milk. I have a question here. Do you give recommendations for starting solids? So as mentioned, solid foods around 6 months. The calories don't really count until the kid's 8 or 9 months old. It's not like they're getting all the food from the they're not getting the calories from the food, they're getting the calories from the milk still. So they can keep breastfeeding. And often people think that, as soon as they start feeding them, they need to, rather like with breastfeeding, they need to feed loads and loads of food all at once. And they don't need to do that. They need to give the baby tastes of different kinds of food. Now, in Greece, there's this marvelous food called crema, which is basically sugar, sugar that you mix with milk. And that's what my mother-in-law, who's Greek, my family's Greek, told me to give all the time, and my Greek family was pushing that. I didn't give it, but crema is one of the sort of porridgey foods full of sugar, which is not necessarily the best thing. What you want to give them really is stuff that's got iron in it, because iron is a short supply, and also food that they can easily eat. So other foods that are rich in minerals are things like bananas, avocados, iron fortified cereals that are sometimes, and we've worked with Help Refugees on this, I mean, in some of the camps, they don't have a lot of food at all. So you really may have to give them the food that is, even if it's got sugar in it, you need someone like us or somebody who reads Greek to read the label and see what the most bang for your buck is. You want something that's got ions, minerals, and calories in it. And if it's got sugar stuck in it as well, then, you may have to live with the sugar. But ideally, you want to give them things like avocados, bananas, even meat, like squished up meat. Meat has a lot of iron in it. It just needs to be palatable for them. They need to be able to eat it and swallow it and chew it. So that's what we recommend for solids. And again, I mean, feeding solids is a whole new ball game, really. The sort of stress that everybody's under, including the children. We often hear that children don't eat, and it's really difficult to assess whether they're not eating or not, because the moms are always really nervous that they're not going to eat and they're not going to grow. And so they say, oh, they don't eat anything, but I watch this kid and actually they eat quite a lot, and the kid's like running around, jumping and climbing and screaming. And so you're like, well, this kid looks healthy to me. And developmental milestones are really another important piece of this, baby. And we do a talk on that too. So children should be doing certain things at certain times. By 6 months, they should be able to sit up, and hold their heads up by about 3 or 4 months, etc., etc. And so 2-year-olds that are sort of tying their shoes and climbing, on the table, that's a fairly decent indication that the child isn't weak from lack of food and lying in its bed. So there are other things that are somewhat objective that can help you with that. I've just got a couple of minutes left. I don't know if anyone has anything else they would like for me to respond to. I'm getting texts, but I don't think from you guys. No, they're not. Okay. Okay. So, thank you. I'm sorry I can't sort of speak to anybody, and thank you for sorting me out at the beginning and getting me online. I would love to get your feedback and know what kind of organizations people who came onto the call are from, because we can do more in-depth training if you want. And again, the people who are in the camps can do a great deal to help. So please, well, thank you for your nice comments. Prescription. Sally mentioned, just last quickly, I will mention some places actually give prescriptions for formula, which is like, that's really bad, because then you're kind of pushing formula as if it's some kind of medication, and that's not right. But I don't really have time to go into all the depths of formula, but I'm quite happy to talk about it. We do an interesting talk about the history of infant formula, which is really interesting, actually. I mean, we needed formula in the 1800s because we didn't have anything else, but the way it's been marketed is the problem, as a sort of lifesaver, and it's not. Okay, so Indigo, thank you very much for hosting this webinar. And if you have, I'd love to get a list of the organizations or the people who participated. Go to our Facebook pages and website. And I am leaving the room now, because in 1 hour from now, and I have to get it set up, we're doing a presentation from Cheering, which we have a link to, with one of the head neonatologists in Italy. And he is talking about the guidelines in Italy for maternal child health and how they've dealt with the COVID crisis. So that's a webinar that Cheering and Champs is hosting. And so please, if you have any, if you're interested in that, you can join that, although you may be webinared out by now from the morning. So thank you all for joining. Thanks, Indigo. And let me know if you have questions. I'd be delighted to follow up. And thank you very much for all your support, technical and otherwise. Okay, take care, everyone. Have a good day. Bye-bye.